Please do allow me to introduce myself. I am Andres Cervantes. I'm a medical oncologist working at the University of Valencia, just 300 kilometers south Barcelona. I apologize about my English, but this is what I can do. So it is my pleasure to be here with you. I really like your theme, your life, your responsibility, but it's also some others' responsibility. As I told you before, it is my pleasure to be presenting and discussing for you. I think I have a difficult topic to discuss with you, which is on cancer research, ethics and challenges. I wouldn't like to be too basic, but as I told you before, I'm working at the University of Valencia, and there are several concepts I would like to share with you. The first one is that research is needed as an essential part of future medical development. So research is to create, to elaborate, to produce a better future. But this process of research is really a very long and complex process, going from very basic laboratory discoveries to the implementation of clinical strategies. So the point is that every challenging hypothesis, every challenging fact or discovery has to be proven, has to be validated in clinical trials. So the participation of patients in this process is essential. Again, I would like to underline this. Without research, there is no better future. So we should be involved in this. I'm going to tell you a story. When Picasso was 14, he was a student in Barcelona. He was learning how to draw, how to paint. And then he saw these paintings made by another famous Spanish painter called Enrique Paternina, that is called the Visit of the Family. So Picasso was very impressed on this painting, and he thought on producing a similar one. And then he took one of his relatives to make this painting. You can see this painting, which was when Picasso was 15. This was 1897. And this painting is in Barcelona. And he got a big prize. The doctor is his father. He was not a doctor, of course, but he was sitting looking like a doctor. And the name of the painting is Science and Charity. I got impressed because the principles of ethics are in this painting. You have the doctor, which is worried about. Is really worried, is really thinking how to deliver the best service to this ill lady. The nun and the boy represents the relative, which is the principle of beneficence, how to also get the best service to the patient. But the patient is lying down and she has to decide by herself. So when you think on cancer research, there are several protagonists of this move. The first are the patients, because they are looking for better outcomes. They need that. so they should participate in this process. We have the academic investigators looking for knowledge to understand deeper and to decide better how to proceed on. We have also the pharmaceutical industry because, you know, our society has given the pharmaceutical industry the responsibility of getting new compounds, new targets, new things to be given back to the society. And also, the civil society is very much responsible of this because this process, how to be very well regulated. For example, what are the priorities for research? Those priorities are established by the society. So then this is a process that should be shared by all stakeholders. At this moment, the next question is, what is ethics for? I'm going to tell you a story. There's a famous Spanish writer, the name is Javier Marías, and his father was a philosopher. So when this famous writer was a boy, he asked his father, "Dad, what is your job?" And the father said, "I'm a philosopher." "Come on," he said, "I cannot go to my school, to my friends in the school, and to tell them you are a philosopher because they are not going to understand." So then the father told him, "Well, you can tell them I'm a professor, or I am I don't know, a writer. Tell them whatever you like." No. But what is philosophy for? And the father was very convinced. Philosophy is to life, to have better life, to think about problems, to solve issues. So when I teach my students in the palliative care course I'm having at the University of Valencia, I always start the ethical issues in clinical medicine with what is ethics for. So if medicine is for health, if science is for knowledge, what is ethics for? And I have to tell you that there are only a few that are getting the right indication. Ethics is to make people happier. Ethics is about happiness. And that's very essential of the human being. So we have several approaches for ethics. Aristotle wrote 4 books on ethics. Almost 2 of them are lost and are versions of the definitive one. The Nicaean ethics is bright, but he wrote one of the books for his son. It's called the Nicomachean Ethics, because Nicomachus was the name of the son. And it starts with a sentence telling that everything is for good. If you follow ethics, it's because all you move is for good. So that's good. But Immanuel Kant went deeper into this concept because ethics is a need. We need ethics to live, simply to live, because it is not always related with good things. And Kant wrote, even if all of you behave like devils to live together, you need ethics. So it is a matter of sharing the principles, the attitude of life. So I think that's important. And one of the also of the sentences that are very basic for the principle of autonomy is that one, that an individual is an aim in him or herself and cannot be converted in an instrument to someone else's aims. So that's a very basic principle we have to accept. So those are the classical principles of clinical ethics. The first one, of course, our society can elaborate on that, is the justice principle. So we have to be treated with quality. No differences should be taken based on that. The second most important one after the justice is the autonomy principle, and this concerns mainly, of course, patients, because patients are the owner of his or her own life, and then they have to decide on that. And then we have some other two principles that are important, but somehow they are equivocal. They have some uncertainty because, of course, everyone is willing to do good things, or things that benefit patients, and things that are not doing harm to patients. But this may generate some conflicts, because you may think that something is very good for you, and the same thing for another person could be very bad. So then those principles are to be discussed. So justice at this moment, in general, as a principle, concerns the distribution of scarce health resources. And we are living in a perfect storm, because we have a scarcity of resources, and at the same time, everything, particularly health resources, are very expensive. So this is a very difficult situation to manage, but it's there. And I mean, the society should have a strong position in this. Of course, the autonomy, the patient has the right to refuse or to choose their treatments. Beneficence, taking actions that serve the best interests of patients. And non-maleficence, that principle of first do not harm, that is very difficult in oncology, because sometimes we have to harm somehow to get a better outcome. So I would underline some ideas of the principle of autonomy, because it recognizes the rights of individuals to self-determination. This is rooted in society's respect for individual ability to make informed decisions about personal matters. And this is related with the topic you were discussing before, the ability of communication. Because how the principle of autonomy is made concrete is with the informed consent. But the informed consent, it is not only a point of signing a paper, telling that you agree on something or not. It's a process of, because without the right information, you cannot get the correct consent. So it's a complex situation. Sometimes it requires several conversations to get into the right point. So autonomy has become more important as social values have shifted to define medical quality in terms of outcomes that are important to the patient rather than medical professionals. So that's a very basic. So the health system is to be centered into the patient and not in the professional. The professionals are to serve patients. So what are the challenges we have? So first, how is the informed consent implemented? How is patient satisfaction assessed with respect to this procedure? We don't know. I have just little information on that. How can patient participation in cancer research improve? But also, how can be patient participation in research design implemented? How can patients participate in defining what are the priorities for a given area? Those are challenges that we have to meet, and we have to try to do. So at the very end, everyone is in the same painting. So the doctor, the patient, the relatives. So then I think it's important that we acknowledge that cancer research is a long-term process. Some points couldn't be envisaged when a particular study is designed, but they may appear when data evolves. And I have to say that our system for doing those consents now is very bureaucratic and very rigid. So I think one of the points is that if the informed consent could be wider, allowing the use of clinical patient-derived material for emerging research issues. I heard in the previous presentation some of you telling that authorities are more concerned on confidentiality than individuals. And that's something that, for example, ESMO, as the Organization for Medical Oncologists and Patients Organizations, did lobby in the European Union to get a better EU directive and simplified directive to achieve that point. When you sign your informed consent and you are donating some blood or some tissue that came from from a patient disease, this could be used for research related to that particular project without going back and forth, asking extra bureaucracy, extra permission to allow that. And I think this is a good example that we need to go together, because there are so many things to do, and as partners in this undertaking, we should go together. I would like to thank you, and I will go for another painting. So this is Goya. Goya didn't got colon cancer, but when he was 73, he got fever, and he got a very bad, most probably salmonella infection, and he was very ill when he was, as I told you before, 73 in Bordeaux, and he was, you know, the classical paintings are making jokes or making negative view of doctors. But Goya felt he was so well taken care of himself by his doctor that he painted as a thanking process this beautiful painting that can be seen in a museum in Minnesota, where far from here, where is dedicated to Dr. Arrieta that took care of Goya. And I think this is another example of how being together we can achieve something that is important. So, thank you very much. I think I tried to be quite open. So if you have any questions or any points you would like to put forward, I'll be happy to take them. Okay. I think the participation in clinical trials is being recognized as an important problem. And when I propose my patients to participate in those trials, that's okay. But there is an area we should improve. And sometimes we have trials in which many drugs are studied, and with negative results. So, who is taking on the responsibility of deciding what are the priorities? So, the academic institutions, the industry that have more money can put forward the trials they are interested in doing. I think at this point, almost everything has to be done. So we have some example. Unluckily, I do know very well this issue in Europe. But for example, in US, when research grants are given from the National Health Institute, patients' organizations are involved in that process. Not only to set the priorities, but also to consider what are the aspects of research that are more needed, more patients-oriented, and I think we should aim at this direction.
I was wondering whether Patrick Nico is here from the EORTC, if you would like to say something, because you've been looking at this in some depth, haven't you, about involving patients in the early stages of clinical trials.
So, hi, I'm working for the EORTC, so the European Organization for Research and Treatment of Cancer. And actually we are building an initiative called Spectacular to build a screening platform for screening biomarkers for patients with colorectal cancer, advanced colorectal cancer. And I would say that we tried since the beginning of the project to involve patient organization. We had the chance to, I had the chance to be in contact with Yola and with Barbara Moss. And Barbara has reviewed our PNSNC, our protocol, our patient information sheet and informed consent, give some comments. And actually, 2 days ago, we had our first steering committee, and we have a chair for a patient representative, and Barbara is a representative she's representing patients. And I think that in the next step, we would like to be more involved, that World Council UK, Europe, are more involved in this platform, because the point is really to screen patients within Europe, to be involved, to be screened, to enter clinical trials, depending on the biomarkers. So if the patients are not really, I would say, aware about what is a clinical trial, what is the benefit to enter research, because you are very well monitored in clinical trials, I think it's easy. So that is why at the EORTC we try to really liaise with patient organization, and especially in colorectal cancer.
know that not everyone would want to participate in that, and as you said, some people don't feel informed enough. But the aim is to make this accessible, to make it at every patient's level. I think that's important.
Thank you, Barbara. I know that's really important what you've just said. Just before I hand over to Wolfram, can I say that Patrick has a stand, the URTC has a stand outside, and if any of the affiliates or associates who are here would like to know more about the progress and how they could be involved, please go and speak to Patrick Rigaud on his stand. Wolfram.
I'm the survivor of colonic cancer since 4.5 years. And I was lucky to be sent to the Essen, Germany University Clinic. And I was integrated in a study. It was a comparison of folfiri regimen, one with Abitus and the other one with Avastin. I was in the Avastin group. And I must say, I also had a part of the colonic cancer. I had metastasis in the liver. I was first very skeptical, but the outcome, the quick response of especially the liver metastasis, was very surprising to me. And I still am glad I'm now 1.5 years out of therapy. So I'm glad that it helped me in first row. And I'm glad too that it maybe will help other patients. And what I also must say, what is very important in this case, the relationship to the doctor, to the oncologist. It must be something like a friend-to-friend situation. Then the patient can develop confidence. And out of confidence, you can develop hope. And I think these are very strong effective components, and which are paramount for the healing process.
Thank you. I think your statement is very important, and it shows what is the level of generosity in general of patients, because when they are asked to participate in a trial, normally they say yes. So, I mean, they are willing to do something this better. They wanted to participate. So, at a different level, for example, I have to tell you that in Spain, concerning the ethical committees reviewing the trials before getting approved, it is mandatory that lay people are in the committee. Not only, lawyers and so, but also patients' representatives. So this is another way of implicating people in the process of clinical research, not only as a patient participating, but also in different points of this process. I think we should move on to get the opportunity to, and perhaps we can. Yes, because after every presentation we can have a while to discuss, and some topics will come back and some other new will come, and so then it's my pleasure to introduce Professor Emery de Gramont. I've been cooperating with him since early days, and he's delivering a presentation on how to understand predictive and prognostic markers. So, Emery, what?
Thank you, Andres. Thank you, Jola, for inviting me at this meeting. It will be a very pragmatic presentation, but sometimes I have, because I'm getting old, so I've known the full story of medical oncology in colon cancer therapy. The news when I do this kind of review when we go back, the patient with stage 3, when I opened my textbook, had a survival of only 25% when I started my studies. And today, these patients have much more than 75%. So that is a real achievement. So here, all of us are involved to try to, again, improve this result for all of you. So here, my lecture is about markers. I've heard the word markers here. This is not a miracle, it's markers. So we will discuss the predictive marker, the prognostic marker, and even a third class of marker that is not very well known, a complicated name, it's the surrogate marker. So I will start with the prognostic marker, because it's easier, it's easy to understand. The marker has an effect of the clinical endpoint. It can be survival, it can be progression-free survival in patients who have a metastatic disease. So it is very important to identify prognostic marker, and I will show you how we do. This is from a study performed by our group and recently published. The goal was to do a new classification in the patients who had metastatic colorectal cancer. How we did that? We took, marker can be very simple. It can be, why not, age. You see, we analyze each parameter in the patient who enter in this study, like age, the sex, the performance status, it's the general health condition, the number of metastatic sites, the liver involvement, yes or no, the primary location, read that on the slide. If the patient has received the adjuvant chemotherapy, some marker that can be found in the blood, like LDH, alkaline phosphatases, or CA as a tumor marker. So then the statistician is looking at each of these parameters to define those who can have a prognostic value. This is just the first step. And here, in this example, the performance status, the number of sites, LDH, alkaline phosphatases, all these parameters, CA, were found have a prognostic value. But you cannot do all the markers to everybody, so you have to combine this biomarker, and the process is to do a statistical analysis called a multivariate analysis, meaning you put all the markers together to find those who are really independent. And doing that, 3 markers emerge, like the performance status, the number of sites, and LDH. All other markers disappeared. What we have at the end, we have to rebuild with this new biomarker a classification to recognize the populations and to look if our classification is better than the older one. This has been done in this paper. And at the end, you see there are 3 different curves. One curve, the patient with good prognosis, those with intermediate prognosis, the green curve, and in orange, those who have a poor prognosis. Doing that will allow us to better select the treatment according to the severity of the disease. So this is the main achievement of the prognostic marker. We have also a marker not only for the patient with metastatic disease, we have a marker for the patients in the adjuvant setting, meaning the prognostic marker that will help us to define among the patient here with stage 2. The stage 2 have a good prognosis, but some patients can even, with a good prognosis, recur. So we look at the prognostic biomarker that can help to define better the population. It's very important for this patient because if they have a very good prognosis, many of them do not need to be treated. When the risk is only 10%, if you give to everybody a treatment, 90% of these patients are already cured. They have no benefit, they have only the side effects of the treatment. The treatment is not working for all the patients. If you have still 7% or 6% of the patients that will recur, so it's only 2 or 3% of the patients that will have a benefit. So it is very important to recognize who should be treated. Here you have an example in patients with stage 2. We looked at the size of the tumor. We look also at, I will discuss that later on on the predictive biomarkers, some definition inside the tumor, and this can also be combined with a new genetic test, which is called the recurrence score, and we can define, looking at this curve, the risk of the patients. For example, here in the green curve, this patient with T3 and mismatch repair proficient, when they have a recurrence score which is at least 30, they have 15% chance to relapse, and this is meaningful for the treatment at the present time. If their recurrence score is less, they do not need to receive an adjuvant treatment. So you understand the prognostic biomarker help to define the population and to select the kind of treatment if they have an advanced disease and if they should be treated or not in the adjuvant setting. Now it's a little bit more complicated but very useful. What is a predictive biomarker? A predictive biomarker is shown here, and the marker. The effect of the treatment on the clinical outcome, the patient will be cured, will have a long survival, depends on this marker. So it's much more difficult to find a predictive biomarker than a prognostic biomarker. Some examples of this predictive biomarker. Some tumor cells can express a receptor called HER2. And this receptor is part of a signalization pathway that is asking the tumor to proliferate. So if we can stop this mechanism, then we have an effective treatment. So this HER2, when we have this HER2 receptor on the cell, there is a drug that is coming on the receptor. It's a monoclonal antibody shown here. So the monoclonal antibody will stop the pathway, and the tumor cells, if this pathway is important, is blocked, and the tumor cells cannot proliferate. So it's very important to find such kind of biomarkers. So here I took the example of HER2 because not in colon cancer, in gastric cancer, 20% of the patients have an overexpression of HER2, meaning that the drug Herceptin could be active in these patients. And you have here the survival of the patients who receive Herceptin in addition to their chemotherapy, and they are doing better than if they do not receive this drug. HER2 is very important in breast cancer, 20%. It's very important in gastric cancer, 20% of the patients. And in colon cancer, nobody is looking at HER2, but 3% of the patients have tumor cells that express HER2. So we have a subpopulation of patients with colon cancer that may benefit from a drug that is not yet used for these patients. Another example, this example is in lung cancer. Some patients have their tumor cells that express another biomarker called ALK. And if they receive a drug that can block these tumor cells, they enjoy a much better survival than if they do not receive this drug. Since these are predictive biomarkers. And in colon cancer, it's like for HER2, a very minority of patients, a few percent, do have this biomarker, and they could benefit of this drug if one day it is available for treating the patient with colon cancer. So this and here we are going back to colon cancer with the EGFR, epidermal growth factor receptor, and the KRAS. So you have here the full pathway coming from the receptor to all the steps that says to the tumor to grow. And we can block this pathway with a monoclonal antibody that will impair the ligand to go to the receptor. When the ligand is going to the receptor, you activate the pathway and the tumor can proliferate. If you give the monoclonal antibody, you block this pathway and the tumor cannot proliferate. But we know in colon cancer that some patients have a mutation in this molecule named KRAS. If they have a mutation of KRAS, the monoclonal antibody cannot work. The pathway is always active. So it is very important, and the patient know that, if they are treated for colon cancer, we have to look at the KRAS status of the tumor. And if we identify this status, it's because the patient who have a mutant KRAS will not respond to the monoclonal antibody, as it is shown in this slide. You have the population who have wild-type KRAS, they benefit from cetuximab, and those who do not have the KRAS mutation, they do not benefit from the drug. So you select, it's a predictive biomarker, because if you have a mutation of KRAS, you should not receive the drugs, the monoclonal antibodies that target EGFR. And based on this finding, we do in colon cancer now additional analysis inside the cells, not only the KRAS analysis. KRAS analysis, 40% of the patients are KRAS mutants. They could not benefit from the monoclonal antibodies. But here, if we do look at other biomarkers on the same pathway, like NRAS, then you increase the population of the mutant population. And again, if you look at another biomarker below RAS, named RAF, then you increase the population, the mutant population. So that is not a good news for the mutant population. But it is a very good news for the patient who do not have the mutation, because here the drug will be much more active. You see a little part of the activity if you treat all the patients. But if you select only the patients who have all the reasons to be receptive to the monoclonal antibody, then this patient will have much better results. And this has already entered in the guidance for industry to enter in the new clinical trials. It's what we call the enrichment strategies for clinical trials. If we know better the patient that will enter in a clinical trial, the chance that we will find a new drug is much better than if we treat all the patients. This is the main interest of the predictive biomarkers. Now, another predictive biomarkers, which is not now for the patient with metastatic disease, but those who have been operated on the tumor. So we are looking to reduce the risk of relapse. And here we have in colon cancer another biomarker called, complicated name, mismatch repair mechanism. They are deficient or proficient. This mechanism of action is linked to the ability to repair the DNA. So if some patients can lack of the mismatch repair mechanism, and then they are exposed to develop tumors. But on the other hand, if they have some problems to repair the DNA, when the cancer is there, it's also more difficult for the cancer to stay and to remain active. So we have this incredible data in the population who have a deficient mismatch repair mechanism. They have a better outcome if they do not receive the classical drug fluoropyrimidine. We can select a subpopulation that has a predictive biomarker saying that they don't need an adjuvant treatment. So this is true for the patient with stage 2, but not for the patient with stage 3. So that is what we have at the present time in colon cancer. We have the beginning of a biomarker classifications based for the patient with metastatic disease on KRAS. We have the wild-type patients. They should have additional analysis to find if they can be responsive to the treatment, the monoclonal antibodies. If they are mutant, we can look even at some other biological issue to find subpopulation that would benefit of any treatment. In the adjuvant setting, the mismatch repair status, if the patient are proficient, a prognostic gene signature that can be given to these patients. So we can try to do even better with the molecular classification, looking like in other cancer at different classes of tumor to find the best therapeutic option. So I believe that this slide is quite complicated. It's also, even if it's very new, you see it has been communicated at ASCO this year, but for some part it's already obsolete. With new drug, we have to reassess if it is always true. Now the last marker that we can have is a surrogate marker. This is more complicated, but very important too. You will see why. Here, the treatment effect on the surrogate is mandatory, as well as a correlation between the surrogate endpoint and the true endpoint. Look at what it is on this example. We are using one drug to treat a patient with colorectal cancer. 5-fluorouracil is the most used drug. If we use 5-fluorouracil, we will increase the survival without progression of the disease. And if we increase the survival without progression, the progression-free survival, then we should also improve overall survival. So the progression-free survival is an event that depends on the treatment, that occurs earlier than the survival, and is correlated with the overall survival. An example, a practical example. In patients in the adjuvant setting that we are treating to avoid a relapse. Here we have a correlation between the disease-free survival, that is the patient who have no relapse, and the 5-year overall survival. So at 3 years, the patients who do not have the relapse are those who will be alive at 5 years. So this is very important because having this surrogate for survival, we can say that the endpoint will occur at 3 years and not at 5 years. We don't need, with a surrogate marker, to wait until the 5-year survival to say that we have a better treatment. We know that even at 3 years. So this allows the patients to receive earlier an active treatment for their disease. It goes faster. We need less patients to demonstrate that the new drug is active, and it's why it's so important for everybody. And it's also very important on the economic part. This is just a picture to show that in the past, to change the standard of care, it is an example in the patient with advanced disease, we needed only 150 patients in the trial to change the standard of care. Then, when we tried the combination chemotherapy, the number of patients in trials increased. The median is already over 400 with the chemotherapy combination. And with the targeted therapies, those new agents, the clinical trials now have more than 1,000 patients. You can imagine that if we continue like that, the cost and the problems to get new drugs is absolutely a major problem. So, and it's also a major problem because if we increasing the size of the trial, you can show much smaller differences between a new drug and an old drug. But doing that, the benefit is too small and the cost is too high to afford this kind of new treatment. So it's why it's a part of my professional life with the foundation, the ARCAD Foundation. We know this problem. This is a paper written by Richard Shifsky, which is a very important doctor in the US. We have to have safe and effective drug. But with the rules that we have, especially for the targeted therapies, we will need thousands of patients, hundreds of millions of dollars, and more than 10 years at least to get a new drug. So this is certainly, it's no more possible with economic crisis and the ever increasing cost. So it's why ARCAD Foundation had inside the foundation an ARCAD group where we collect the databases of all the trials that have been done in the world in the field of colorectal cancer. And the goal of this huge database is to find new endpoints, to find new surrogate endpoints, to be sure that the drug is active in a shorter period of time, with less patients and with less money. For example, we looked at the effect of PFS and overall survival. The correlation is no more observed when you add new drugs compared to the old time. We are looking at very early objective response linked to the treatment. And this is the part of a scientific work. After this scientific work, we will try to find a consensus between the doctors, a consensus between the doctors and what we call the authorities, like FDA, EMI in Europe. And after that, here you will be involved. We will have to do a lot of lobbying to impose new rules for these trials. And I hope to have success to help us to have better drugs and to affordable, new and very active drugs. So this is a very important process. And to conclude, back to this presentation, you know now that we have three kinds of biomarkers. The prognostic biomarkers that are easy to find. They are very helpful for a therapeutic strategy. We have the predictive biomarker that are more difficult to find, but when they are here, they allow us to avoid the ineffective therapy, and it will decrease the cost because only the patients sensitive to the drug should be treated. And we have surrogate markers that will help us to reduce the size of the clinical trials, and doing that we will reduce also the cost and have our drug much faster. Thank you.
Yes. So thank you, Emery. Are there any questions coming from the audience?
Trials done more quickly. Are we saying if we're looking towards using a certain stage of trial? So like now we have phase 1, phase 2, phase 3, phase 4. Will these master new trials miss out one of these phases?
So these endpoints are most devoted to the phase 3, the last stage when you have the drug approval. But the process to develop has also to be revisited for earlier stages too.
I hold this microphone always. Does somebody else like to ask any more questions? Do we all understand predictive and prognostic markers now?
And surrogate.
And so we will be tested tonight. When we have our reception, I will be going around and asking you. So ask now while you have a chance. Okay, everybody's going to get 10 out of 10. Well done. Thank you very much.
As a comment, I would like to say that we have a process now that takes about 10 years to produce an efficient drug. And this is too much. I mean, this is very difficult. And also the point is that the rate of failing in producing new drug is very high. So then we have to improve on the systems. We have to get predictive factors since the very beginning of the process. So when you have a predictive factor and you can start your early phase 1 trials, taking into account not only the good actions of the new drug, but also the good selection provided by the marker, I think this would be a much better situation for developing new drugs. On the other hand, we have at this moment, there are more than 900 new drugs being developed in the cancer area. So it's a hard work, and I think we should optimize this process. The classical way won't be working anymore. So I don't know if Harpreet is coming. Oh, Harpreet, nice to see you. So then the next presentation is entitled Hope for Patients with Advanced Colorectal Cancer, and it is my pleasure to have in the podium Dr. Harpreet Wasem, working at the Imperial Cancer Research in London.
Thank you very much, Andreas, and to Yola and all the organizations again for organizing this fantastic meeting. As you'll see from my talk, it's very humbling how much we continue to learn from patients, and the talk about spectacular I'll come back to when I talk about the trials in the context of this, so I'll come back to that. So, I mean, we're moving very fast forward with developments, and Amory was talking about mostly stage 2 and stage 3, and I was really sort of talking more about stage 4 in my talk. And, you know, survival has at least tripled in the last 30 years in terms of patients who were deemed incurable. And things are moving very fast in the context of colon cancer becoming like other cancers, like breast cancer, myeloma, leukemias, where people are being offered many lines of therapy to control the disease. The number of potentially active drugs is also increasing rapidly. You just heard from Andreas how many drugs we're going to have to investigate coming up and the challenges for that. But we also have another interesting paradigm in colorectal cancer where a lot of other cancers don't have that option, which is that there are many non-drug technologies which might help our patients because patients can be cured from with liver surgery even though the cancer is spread. And the risk and safety of these interventions is decreasing all the time, so it makes it easier to integrate. So in good liver centres, mortality after liver surgery is near zero. And I tell my patients that when I talk to my pancreatic cancer patients and they need surgery, I'll say this is one of the biggest operations you'll have. When I talk to my liver surgery patients nowadays, I'll say that actually patients are often out of hospital with laparoscopic surgery within a few days, and now people are revisiting doing liver and colon together again because the liver surgeons have progressed this field so well. So, you know, all these developments are really, really important, and you can see from the drugs that we currently use and the 2 or 3 new ones that are coming through as well, that whereas I thought perhaps we were reaching a plateau, we're not necessarily reaching a plateau. In fact, you can see the curve is sort of beginning to rise again. And that might be for many reasons that I've already described, and it might also be for reasons of us understanding and selecting our patients better, but also making sure that we offer our patients as many treatments as possible. But it is encouraging to see that curve is on the uptick, and in fact, in the last few months alone, we're moving again forward with the way we think about selecting patients and sequencing drugs. And then, of course, I've talked about liver surgery can cure some patients. The important thing of this is that whereas Amory talked about the improvement in survivals in stage 3 cancer survivals, we are now reaching stage 3 cancer survivals in some of our liver metastases patients. So that's a huge step forward. We've almost made some stage 4 patients equal to stage 3, while stage 3 accelerates even further ahead. So hope is also not just in survival times, but also quality of life, and this is continually improving. Because we have better selection, because we have a better understanding of side effects and management, and I can't actually overemphasize how important this is. We also have better patient education. We obviously can improve on that even more. We have more choices for our patients. We are now beginning to think of how we could reduce the cytotoxic component of chemotherapy for times, so that we think of treatment breaks, we think of de-escalation of therapies, staying with the biologicals and moving away from chemo all the time, and maintenance comes into that concept. So these are trials that are reporting right now. They're contemporaneous trials, so that we're really excited by the fact that we may be able to have treatment breaks, treatment de-escalation, so that you're on minimal therapy when you've reached a maximal benefit point, so that we can maintain that maximal benefit point for as long as possible. And in some of those patients, again, as I said, there's conversion to cure. So better patient support is also available in a holistic way. I was told, I don't know if there's anyone from Australia, I suspect there's not. Is that right? No one from Australia? I've been told that their government is funding gymnasiums, and you know this for breast cancer patients, by the chemotherapy units. And that's because it's been shown to improve fatigue if you keep active during your treatment. So these are things that we just didn't even consider or think about. But now we have to be very proactive in the patient in many ways. And of course, many organizations like yourselves provide patient counseling and support, but they're also fatigue can interact with that in such a big way that we really have to tackle it. We're also doing a trial in another disease area, in pancreatic cancer, where the drugs are not improving the outcome for the patients from a point of view of the cancer necessarily, but they're looking at improving the muscle mass and the bulk of the muscle bone to prevent fatigue. So these are really critical developments that are going to be important. So coming back to the question that you've already talked about as earlier on in the talks, is about the participation in research and clinical trials. And again, I can't overemphasize how much we have to thank patients for this. So I have to put my 2 bits in for what you've already discussed this afternoon. What I would say is that something I wasn't planning to talk about, but I'll just digress for a minute, is the spectacular initiative. As some of you are probably aware, the largest and most complex colorectal cancer trial is launching next Tuesday in the UK, called Focus 4. And Focus 4 is, in some people's views, 10 years ahead of its time, because we're not really sure whether we're getting it right. But we have to start somewhere. So you can start with Spectacular, which is profiling patients. What we're trying to do in Focus 4, because of all the emergence of the new drugs, is rapidly partnering patients, pharma, to say we've got the profiles ready and we're going to stratify you into little groups, and try and, exactly what Yola was saying, is try and push that boundary of testing phase 1, 2, 3, 4 embedded within a trial. So we're testing safety, then we're testing for lack of efficacy, then we're testing for efficacy, and then you can move out into your randomized phase 3 or whatever. So what we're trying to provide in the UK is it's a really complex trial. There'll be over 2,400 pages, the most expensive colorectal trial, and we're grateful to all the organizations that are supporting us. And it's a huge endeavor. It's taken 3 years in planning with the statistics and everything, and we don't know whether we've got it right. But it's a start, and if you don't make a start, you can't move forward. And the concept was very much, very badly received by the pharma industry about 2 or 3 years ago. But now we're getting a lot of discussions with them where they want to think about this, because how else do you test the 900 drugs that Andreas mentioned? So it's quite interesting that you can have paradigm shifts through clinical trials as well. But the one point I did want to make is that as recent as last week, when we were discussing the launch, we had 2 patient representatives, of course, with us all the time. They had a fantastic suggestion that we didn't even think about. So what they said was, in the launch meeting, they were going to model a patient being consented, because this is a really complex study. So in Focus 3, what we did was we actually created a DVD, and because there were so many arms in the study. Now, this is a very complex study we're about to do. And that was, we just thought, well, why don't we think about that? And of course, it's a fantastic thing to do in a launch meeting, because it really gives the people who come to the launch meeting, the nurses, the doctors, who are going to consent the patients, a perspective that they may not see when they start doing this study. So it seems so obvious now. Why didn't we do it? And we are going to do it. We're going to test it. So I just wanted to digress, because it just goes to show you how actually the patients make a huge difference to the way we not only change our trial ethos, but also the way we run and design trials, not just at the phases you were talking about earlier on at the beginning, but also when the trial's about to launch and while the trial's running. These are really important issues. So patients have to be aware about all these excess of choices. They have to ask lots of questions. In the UK, it's a little bit easier because we're peer-reviewed. We have to, some of you know about this, that we have to be accredited as a centre. We've got national peer review. And the document that is being discussed in a multidisciplinary meeting is available to the patient if they want it, to show that many people have been involved in their decision-making process. And this has been going on for many years. We have to audit our outcomes. We have to give the patient a copy. We have to give the GP a copy. We have to give them our contact information if they don't agree with us or they want to ask questions, and that is important. But there are other questions that patients have to ask. So there's still quite a lot of demand on some patients find this easy, some patients find this very difficult, to make sure that all the things they have access to and want to understand the choices. And sometimes physicians and doctors fail on this for various reasons. So we have to improve our education. But the fact that we've got lots of questions and lots of choices is actually a very important aspect. And that's hope for us, because it means we're expanding the options for our patients as well. So a lot of learning to do around this. So when I was going to talk about when I was preparing this talk, I wanted to also understand that a lot of the day will be about drugs and drug development. And I also wanted to show you that there were ways that you can work on patients and help patients with colorectal cancer without even thinking of drugs. So the standard way might be we're going to use more and more drugs. So there's been a trial presented recently with 4 drugs showing a very high response rate, but we have to be cautious about toxicities and side effects. But there are a lot of targeted treatments that are available that are not necessarily drug-related. So liver-targeted treatments, for instance, are available now, and so you can target the whole liver with drugs or with particles, with radiation, which I'll show you in a second, that don't depend on having chemotherapy every week, for instance. And these are quite interesting because they may have a big return in a particular organ for a short investment. So a liver surgeon is a good example of that, but a lot of people are not suitable for liver surgery, so you need to offer them all sorts of other therapies. And then, of course, there's other therapies available that have been around for a while, which are evolving, which are what we call targeting what you can see. So you've got a spot in the lung, or you've got a spot in the liver, and you destroy it in some way, either through heat. And these technologies are moving very fast. So there's a whole list of technologies there, which I call visually targeted. And they're pretty similar in what they do, but they have different profiles of toxicity, side effects. And there's a lot of work to be done, just like in clinical trials, of proving that they don't harm our patients as well. So it is quite amazing that these are moving forward, and the impetus is not just on drug clinical trials to show that toxicity isn't going to be a limiting factor, but there is some issues about whether the more drugs we use, the more complete responses we can get. Some people believe that this is going to happen, some people don't believe this. And the other thing that I wanted to say is that we have to make sure that we do offer all our patients the possibility of liver surgery if it's appropriate, because all these other technologies are not going to be as good as the liver surgeons, because they have a visualization of what they're actually removing. So even the sequencing, the way we offer this, is very important for patients to understand. They could be compromised in some way. So this is an example of very complex technology that if you look at it and I present it to you today, you'd think, how would we integrate this in patient care? But we've done it in our institute, and many institutes in Europe and the world have done this. And the reason is because we've never been able to give radiation safely and very easily to the whole of the liver. And this is technology that's come out of Perth, University of Perth in Australia. There are other similar technologies where these little particles actually deposit in the liver. If you give them through the groin into the liver, through like you have a heart angiogram, you're having a liver angiogram, and you deposit these particles. And in the US, they do this as a day case, even though there's huge doses of radiation. And the reason they can do it is because when the particles deposit, they create a really high density cloud of damage. But this cloud of damage is literally only 1 or 2 millimeters. And it's absolutely huge doses of lethality where these particles deposit. And you get doses which you can't deliver with external beam radiation. So for me, these technologies are all nice, but I have to show that they're safe, and we have to show that they're efficacious. So we decided, based on this, because we were getting some very effective data from other centres, to take this on and run a clinical trial around this, which is running right now, which I'll show you a summary. But what you can do is you can actually say, well, the patient can have chemotherapy, which is their standard of care, and they can integrate this in an interval in their chemotherapy to get an even higher return for the liver. So a good example is a patient who's turned down by the liver surgeons after 6 months of chemotherapy, and you think, well, I want to convert that patient to liver surgery because that's actually the thing that might give that patient long-term cure. So that's the reason we took it on, and we're running the trial around that. So that's the trial that's running, and in fact, although it was very slow to start, 518 patients have been recruited in the global part of the study, which is many centres in Europe. In fact, Europe has been leading the way in terms of recruitment, and Australia. They've been very, very fast recruiters, and we're very grateful to that. And then we have the Foxfire trial in the UK, which is about half recruited. And actually, when we combine the data, it will be one of the biggest studies ever testing this technology. In fact, it will be the biggest study ever testing a non-drug technology in stage 4 colorectal cancer. So you can convince people who make technologies, not just drug companies, to actually run clinical trials, because the downside of it, if they tell me, use this technology, it's licensed, I will say to them, well, I've got to prove safety, I've got to prove benefit to my patients, and if I don't have that data, just like a drug that's coming through, why would I want to necessarily offer it to the patient, just because the short-term outcomes look very, very good. So that's also a very exciting time. And so what we do in our practice, and a lot of people have done this, is that we still stick to the standard way that we treat patients. So this is a sort of a model that one might use to treat patients. But sometimes we think, well, actually, this patient's not benefiting a lot from chemotherapy. The liver surgeons have turned them down. And we can integrate this literally within a week of their chemotherapy program just by stopping the chemotherapy for 4 weeks. And that doesn't seem to do any problems for us. And you can integrate it anywhere along the lines. And in fact, there's so much data now that if your drug options have run out and you've got liver disease, there's so much evidence now that this benefits as like a last line of therapy if you have no other drug options left. So there are other limitations, but we still have some hope. And then one of those limitations might be in the UK, you've heard of NICE, and we have these problems everywhere in terms of health economics. And I don't think, although NICE led the way in terms of thinking about this, I think we will all face the challenges, and you will discuss this, I'm sure, in your debate as well. So I don't think, although NICE is looked upon as a very restrictive environment, the difference was that patients, lobby groups, challenged them, and it took one political statement from the Prime Minister to open a new cancer drugs fund, and we've got access to all the drugs, at least temporarily. So again, patients have made a huge difference. It's actually patient-driven, this new cancer drugs fund, because somehow that information got to the Prime Minister directly, and when he makes a directive, it happens, and he did. And so you can see how groups like yourselves are actually far more instrumental than you may even think today in changing practice. But we will have future limitations in terms of drug costs and drug development, clinical trials, and we have to be cleverer in the way that we actually do it. So thank you for listening. Thank you.
Thank you. Could you stay just if there's any questions from the audience?
Here I go again. This may sound very foolish of me, but how do you actually recruit patients for your trials? What do? Do you advertise, or how?
In the UK, we don't directly advertise. It's not something we've done. There are obviously non-cancer studies which can advertise. So we generally have these trials go through a very rigorous process of peer review, get them accredited by the National Cancer Research Institute, or the NCRN, and then it's advertised naturally because they provided infrastructure to set up those trials within the hospitals in the UK. So there's a sort of core group. And those nurses and research nurses tend to be patient advocates, so they tell patients what are the choices. So to give you an example, a few months ago we had 2 or 3 trials running that these CERT patients could go into, and they were given a choice. They could say, well, these are the downsides of this, is a patient information sheet, which one would you prefer? Then they'd come and discuss it with us. So because of the way we run in the UK in a centralised way in networks, I haven't really found that you need to advertise. I mean, we certainly have enough patients who want to discuss the options of going into the studies. So one of the things of the networks is it's been really good because patients do get a lot of access, really. I don't know what happens in the rest of Europe, but we don't have this problem, really.
Yeah, in general, I think that's so. So participation in clinical trials depends very much on the institution you are going. So if you go to a reference center, then you have a higher possibility to be offered to participate in a trial. But I think this is something that should be worked out, because I think if patients are willing to participate into trials, they should be offered also this possibility. I mean, I understand that if for one patient to participate in a trial, he has to move to another city or whatever, may be difficult. But I think in any area, in any reference area, you may find clinicians involved in trials, and then this information should be available. That's my view. So let's move to the last presentation of this session, which is going to be given by Professor Erik van Kutsen from the University of Leuven on the question, does personalized medicine increase survival rates? Thank you, Erik.
Okay. Thank you very much, Andres, and thank you again to Jola and the team. So it's a difficult question, and of course, but we're seeing some clearly changes. And one message is there clearly, we are moving towards personalized medicine. It impacts, it's not always so easy to demonstrate, but it impacts on the outcome, and that's the only way that we can and that we should go in this setting. Just as a start off, a couple of images of Leuven, where I do live and work, the City Hall and some of the university buildings in Leuven, just east of Brussels. And you're discussing today on different aspects on, of course we want to prevent and we want to cure. There is a long road, but we are making progress. And this personalized medicine topic is part of it. And indeed, it's on different levels. If you think on personalized medicine, we often think of molecular markers, and that markers, KRAS is just one example that was already mentioned, helps us to personalize, to individualize, and to select patients. But that's not the only way where we do personalized medicine. The older use, let's say, or the use of the older stages and the different stages, early cancer, late cancer, so we divide colon cancer in different stages, and you see some percentages of the stage at the initial presentation, meaning that 1 out of 4, 25% of patients who have colon cancer, they have already metastasis. That's a more advanced stage. The approach is different, of course.
I'm 31. I was born in London, actually at the same hospital that I'm going to give birth at in Hamilton. I've always really loved doing anything at all to do with art. My grandma was an artist.
Different goals. The optimal goal is, of course, that we want to cure, we want to prolong survival, but in some patients, also another goal is improve symptoms, maintain or improve quality of life if we cannot cure, and in some patients, in some situations, it will be palliation. And for that, we use different treatment options. We go for surgery, radiotherapy, chemotherapy, and often a combination. An important message, and one of the crucial messages, is that the treatment should be done in expert teams, multidisciplinary teams, according to evidence, according to guidelines, according to experience and expertise, with a specific focus on personalized approach. And in fact, as a clinician, the different clinicians here in the audience, that's what we do. We take decisions on a daily basis. We look into the patient in his history, in his other diseases that he had, his comorbidities, as we call that, in the wishes of the patients, the expectations. Some patients want to go very aggressive, some patients don't want that in some situations. And we look also in the tumor. And then we take a basis, and then we take a decision for the individual patient, a kind of personalized treatment. And for instance, if you take the example of rectal cancer, Erectile cancer, there have been different ways in the past. Waves in the past, it was only surgery. Then many patients were irradiated before surgery or chemo plus radiotherapy. But now the future is again, and we overtreat some patients in some situations, so that we also group the patients in the different groups. Low risk, high localized rectal cancer, for instance.
I'm 31, I was born in London, actually at the same hospital that I'm going to give birth at in Homerton. I've always really loved
low-lying tumors with low to moderate risk and then high-risk tumors. And we are trying to define what are the different groups of patients so that we can also personalize treatment, so that we do not have to irradiate all patients, so that in some patients we will go for surgery, some patients chemo plus surgery, some patients chemoradiotherapy or radiotherapy followed by surgery, and some patients in the future maybe only chemoradiotherapy full stop and no surgery. So that's a kind of personalization also out of the scope of, let's say, the molecular markers. And another example in this is just stage 2 colon cancer. That are the patients with relatively early stage. So the cancer is not spread to other organs, there are no metastases, and it's not spread to the local lymph nodes. That's the definition of stage 2. It goes through the wall, but no spread to lymph nodes and no spread on a distance. Often chemotherapy is considered, but if you look at the trials with chemotherapy, we know in stage 2 that many patients are already cured with the operation only. We know that if we give additional chemotherapy, that we cure some extra patients, 3 to 6%, let's remember around 5% of patients. That means that there are also some patients who have still a relapse, despite the fact that they have received chemotherapy. And for these patients, that's very important that we can, let's say, increase their chances of cure. And that example is not only in colon cancer, that's also in breast cancer, hormonal treatments that are given, tamoxifen from several years. There's also a relatively small percentage of benefit in this setting. The challenge for us as clinicians and for the patients, of course, is how can we determine this group of patients, this 5% of patients who will have benefit, in order that we don't have to give to all patients chemotherapy, in order that we can spare them the toxicity of chemotherapy because they are cured anyway, and in order that we can avoid to give them a chemotherapy that does not benefit them. And that's also a kind of personalization. We cannot solve that question completely. We don't have a complete answer how to determine that. But also research efforts, there are efforts ongoing to try to find who are these patients in this regard that need really the chemotherapy and where we can increase the chances of chemotherapy. And then a third example is in patients with metastasis. And if we're talking on personalized treatment, of course, we often think of metastatic patients. We are having more and more anti-cancer agents, and magazines such as Time magazine cover these different topics also in this regard. And indeed, in colon cancer, we come back from, let's say, 15 years ago, where we had only 5FU. Now we have a list of different cytotoxic, different classic chemotherapeutic agents, and different targeted agents. So the list is expanding. If there's only one agent that is available, only 5FU, then there is no need to find out which patients will benefit more or which patients will benefit less. But if we have a whole list of agents, more agents, then there is really a need coming up to try to select and to determine which patients do benefit more and which patients don't benefit of an agent. And that's the selection of markers that was already probably discussed earlier on in this setting. And there comes a complexity. We have different agents. Cancer is a complex process. It would be very easy if a cancer would be driven by just one mutation. If we would have one mutation and then the cancer would occur, we could interfere with that mutation and we could cure the patient. That would be very easy. But there are many different processes that do play a role in cancer growth, going from growth factors to blood vessels to the surrounding, what we call the stroma or the surroundings of the tumor cells. And even in the cancer cells, there are many different growth factors that do play a role. And I expand a little bit on that. And that's one of the challenges. These are complex slides. The goal is not to go into detail. But in colon cancer, we are now unraveling the different subgroups of cancer. We know that not all colon cancers are the same. We know that there are 5 or 6 different types of colon cancer. So in fact, we should not all name them colon cancer. We should find in the future probably subnames, colon cancer type A, B, C, D, or whatever, according to some of the molecular patterns, because that's coming through. And we now see in highly ranked scientific journals some gene signatures, because it's not one gene, but it's a whole panel of genes probably that determines a specific group. And then if you're going on the level of a cell, this is a cancer cell. This is the wall of a cancer cell. On a cancer cell, we see many different receptors, proteins, and when they are activated, these proteins, they can activate a signal. And if that signal is activated in the cell, then there can be a growth process, can be stimulated, can be activated. And that's what you have to see, and I will explain that in just a moment in another, I hope, understandable way. But you can see that this cancer cell, these pathways, are very complex. That's the metro map of Tokyo. That's Michelangelo in the Sixtine Chapel in Rome. Let's just guess what is the easiest to unravel. It's a challenge. All processes are extremely complex. And that are these, what we call signal pathways. Remember the previous slide? A receptor, a protein on the cell wall of the cancer cell. When that is activated, we have a signaling pathway that is activated, and that goes down, that runs in the cell, and that then stimulates tumor growth. And that's in fact this complexity of the signaling pathways. And that's going back in a little bit a simplified way in colon cancer. The cell again, with different receptors. These receptors are connected to one of these signal pathways, as we call that. And they are a sequence, like for instance, the EGFR, RAS, RAF, MEK, MAP kinase pathway. So that's one pathway. So A, B, C, D. Here you see another pathway. For instance, P10, AKT pathway. So these different pathways are extremely complex. It would be easy if we would know in colon cancer that was just one pathway, for instance, that regulates the tumor growth and that we can block that. But it's extremely complex. If we see, for instance, a mutation in one of the genes here, KRAS, we know that if that mutation is there, that, for instance, or if we block a part of this pathway, that there are feedback loops so that the signal transduction pathway reactivates itself through feedback loops or through crosstalks, that these different pathways, A, B, C, D, talks with this one here, for instance. So there is an extreme complexity, and that goes back to these previous complex slides. And I will not go further in detail. And that's one of the reasons why it's so complex to find really the good markers. On one end, there is a cancer cell. And the previous examples were on the cancer cell. On the other hand, there are the blood vessels. Blood vessels are around the tumor. Blood vessels are shown here, are drawn here on this drawing. And these blood vessels, they also drive and they control, they interfere with tumor growth. And so you've heard in the previous talks that we have drugs that interfere with blood vessels, the so-called angiogenesis inhibitors. They're available in colon cancer. And then there are drugs that interfere with the growth of the tumor cells. And we combine sometimes some of these different agents. We combine classic chemotherapy that works in the cell, and then with, for instance, angiogenesis inhibitors that interfere with the blood vessels around the tumor cell. Let's skip just a couple of these slides. And that's again a schematic representation of the cancer cell with the different receptors here that you can see. So what are we doing then in personalized medicine? We want to find which markers. So if we, for instance, treat a tumor with an antibody against one of these receptors, because, for instance, cetuximab, panitumab, some of the drugs that you've heard about, talking about, they block this receptor. If that receptor is blocked, then the signal, the downstream signal, can be blocked. At least if the patient has no mutation, for instance, in the RAS gene. You may have heard that already. Patients with a mutation in the RAS gene, if we block this receptor, this signal remains active. So the drug will not have any effect in this regard. So that's what we are trying then to do, to see if we block, for instance, with a certain drug, a receptor, can we find mutations or a panel of mutations or molecular markers that help us to see whether we can predict whether the drug will be active or not. And we need that, because if we then go a bit down to the earth, we need that. This is, for instance, an example of patients who failed all different treatment options, who were then treated with these drugs that were mentioned earlier, to use cetuximab, panitumab. We know that around 10% of the patients will have a shrinkage, a partial response, a shrinkage of the tumor. 1 out of 3 of the patients will have a tumor stabilization, and in just over half of the patients there will be no benefit. So that's the image. So that means that we have to find which patients are here and which patients are here who will have no benefit. And that's personalized medicine. We have to find which are the patients that will benefit and which are the patients that will not benefit in this regard. And that's illustrated here. We have to find, with this movie of Clint Eastwood, which are the good, the bad, and the ugly. So which are the tumors that will not respond, or which are the tumors that respond. And we don't have to treat everybody in the same way anymore in the future. And that's also illustrated with some cartoons here. We have to get the right patient, the right drug into the right patient. That's illustrated. You know all the pictures. Everybody is different. Every patient is different. That's logic. But every tumor is also different. Maybe not every tumor, but many tumors are different in that setting. So we should go away from, let's say, in the future, treating everybody on the same way. That's the medians. We should really individualize the treatment. And that's illustrated with an example here. If we would have 100 patients, if we would treat these patients with all the same drug, then we could have a certain number of patients with a benefit. Remember the example that I gave earlier. But if we can exclude some patients, for instance, 4 out of 10 here of the patients that have no benefit, and only direct our treatment towards this group of patients, then the relative benefit will be larger. We exclude these patients. We don't expose them to the economic toxicity, to the financial implications of treating with them, and we don't expose them to the toxicity of the drug. We direct our efforts to the patients who are more likely to benefit. So that's what it's all about in personalized medicine. We're making progress, and I could go on, and I know that's a very complex field, but in this, it's extremely a new science evolving. We are setting up new types of trials, and for these types of trials, collaboration is important. We really need everybody in this. And if we can succeed on that, in this, and I gave you a couple of examples on metastatic disease, also on rectal cancer, everybody will benefit. The physicians, the paramedical team, the friends of the patients, the paying authorities, the industry, and especially the patient, because he's in the center. And with that, with these initial steps of, let's say, the integration of the different treatment options for patients with metastatic disease, and also first attempts of personalized medicine, we are improving. We are lifting and shifting up the survival of patients. There is still a very long way to go, but if we can then integrate with all the different new agents, also more and better selection of patients, more going towards personalization, then the survival will really go up in the future. And that's what we should do. We should tailor, individualize. When we buy a suit, we also tailor it to the person who has to wear it. That's also what we have to do in our treatment options for patients. So to end up with this, are we making progress on personalized medicine? Yes, we're making progress. As a patient, of course, you want to see on a daily basis a progress. You want to go as fast as this. The reality is not yet there. The reality is that we are making progress step by step, year by year, and if you see the different data, progress is really coming true, and that's good news. And really, if we will make further progress, if we can further tackle, and we are in oncology at the turning point of the integration of personalized medicine in the different areas, not only in colon cancer but also in other areas. Thank you for your attention.
Thank you.